I'm going to present some work that I've been doing with colleagues at the Duke Institute for Health Innovation, Mark Sindak, who's a data scientist there, and Suresh Balu, who is running the center. And I guess I should say this is kind of an internal innovation center within Duke, but separate from Duke Hospital. Graphics here. Our bottom line on what I'm going to present today is that employees don't like solutions that make their lives worse. So for AI, for organizations at top manager level, oftentimes AI solutions promise increased revenue, reduced cost, and improved quality. But for the end users on the front lines, AI has three characteristics which makes that different. It's predictive, it's laborious to develop, and it's prescriptive. And that means that for frontline employees, it can result in few benefits, additional labor, and decreased autonomy. So we've identified at Duke 6 tactics associated with successful AI implementation. We've studied 15 AI solutions that have been implemented over the last 5 years at Duke, using interviews with developers, end users, and third-party stakeholders. And we've compared successful versus failed implementations. Here are our 6 tactics, and I'll go through the first 4 today in the interest of time, using 2 examples of successful AI implementation at Duke. One is a solution for diagnosing low-risk pulmonary embolism patients, and the other one is a solution for detecting patients at high risk of chronic kidney disease. So the first thing is because AI is predictive, it raises particular issues. Let me talk about this AI solution for PE. Here, actions taken by upstream ER clinicians had large consequences for downstream ICU cardiologists. So ER clinicians would triage patients, and then the cardiologists would need to treat these patients in the ICU, and there'd be other people in the hospital that would need to treat them. And so the downstream cardiologists were worried about ICU overcrowding, and they wanted the ER clinicians to not admit all PA patients, but instead there were a lot of low-risk PE patients who could be discharged to the outpatient setting. So the cardiologist said, could you please develop a tool that will help us discharge the low-risk PE patients? And so they came to the developers to ask for the tool. But the downstream cardiologists were not the true end users for the tool. And we saw this again and again in all of these implementations where, and it took my colleagues at the Duke Institute for Health Innovation a while to realize that they had to be careful regarding who was approaching them for the tool. Initially, they were so happy to be approached by business unit leaders, but then they realized that it was often these downstream people because AI is predictive and you need to intervene upstream. And so they learned that they needed to identify the true end users. In this case, the true end users' needs were, they were okay with discharging these patients, but they needed to make sure that they were going to get timely outpatient care. So the first tactic is identify the true end users and develop AI solutions to address their pain points. Here, the pain points for the ER clinicians was the timely outpatient care. So they incorporated into the AI solution just a process, not even a technical thing, where the cardiologist said, fine, we'll staff a special outpatient clinic so that we can get your patients in very quickly if you discharge them from the ER. So it was a collaboration between the 2 groups, and the cardiologists were the ones who wanted to benefit from this, so they were willing to do that. The second thing is reward the outcomes the AI solution is designed to improve. And this is really, the first step is just measuring more carefully these outcomes. So previously, ER clinicians were measured on how well they recognized acute common issues. And so with the introduction of the tool, they're also now being measured on how well they recognize and treat low-risk PE patients. This sounds so, like if I gave this to a group of practitioners, everybody would be like, oh, come on, you're telling me I need to focus on the needs of end users. Like, of course, I'm going to do that. And so we found with the failed implementations that there's 2 reasons that's easier said than done. One is that true end users bring their own requirements, and that complicates development. So oftentimes these third parties who approach the developers say, oh no, let's not get them involved up front. They're going to have all their own things that they want. And so it's often this idea of like, let's get the tool far along enough before we bring in the end users. And that ends up being a problem. And then the second thing is that it's easy to say, let's change measurement and rewards, but actually the AI teams don't have control over that. So they need to upwardly influence the top managers to make those kinds of changes. But in our successful implementations, they did do these two things. The second thing is reduce labor for the end users. And I'm just going to use this AI solution that would help primary care physicians both detect patients who needed to be referred to nephrologists because they were at risk for kidney disease, and also reduce the number of low-risk patients who were needlessly referred. So this tool was asked for by the nephrologists who felt like, on the one hand, I'm having all these people referred to me who really don't need to be coming to me. And on the other hand, then I'm getting, pulled into the hospital to work with these patients that could have been caught earlier and have really bad kidney disease. So they came and asked for the tool. And for everyone in this room knows that these tools require a lot of labor. And I tried for a long time to finally I found Duke where they're actually implementing things. I've been involved in so many projects where they say they're implementing and then it's like 2 years later and we're actually still developing. And I get it. But you all know in this room, this is why, like, it's very difficult to do all these different steps. And so one thing in the successful implementations they did is they reduced the data work for the end users. So here, nephrologists were the primary beneficiaries of the tool. So they enlisted the nephrologists rather than PCPs to perform this labor related to data label generation, data curation, and data quality assurance. The second thing they did is reduce the integration work for end users. So I've seen this done in different ways. So in other settings, I've seen this done just by simplifying the user interface, for example, and not requiring end users to enter data that can be pulled from the system, to give them other things that they need to look at in making the diagnosis so that you're kind of giving them not just the prediction by the tool, but also these other things. In this case, they had even more interesting thing they did. Actually, let me explain it first, where they actually have a group, they have a specialist and some other people in the Duke Population Health Management Office who are virtually reviewing the results of the tool. So this, yeah, thanks, it's not time pressure, right? So they have time and they have weekly rounds where they have this group review all of the times the tool is saying, oh, this patient's at risk for kidney disease, and they're making a call of whether they really think it's right. So they're kind of pre-screening for the PCPs. In addition to that, so the PCPs have limited time. I've studied PCPs. They have a million conditions they're looking at. So the nephrologist pre-screens and sends recommendations to the PCP, which are pre-qualified in addition to the tool. They also do some interesting things. Again, we know you should do this, right? But you'd be surprised. People don't always do it. They actually send it to the PCP at the time the PCP needs it. So they know when that patient is coming in next for a visit, and they send the recommendation to the PCP kind of immediately before the patient visit so that the PCP is getting that recommendation when they're preparing for the visit anyway. The other thing they do is PCPs don't want to do all of this follow-up that is related to this. And so they have their care managers do this. And so obviously this is a pretty resource-intensive intervention, but it turns out that it makes sense for the hospital in the case of chronic kidney disease because there's so many downstream costs associated with these patients. Easier said than done to decrease labor. Oh, of course, yeah, of course, decrease labor. But the end users are the best at doing the data work. They know the data idiosyncrasies. They know the best outcome measures. The PCPs are better at this than the nephrologists. Also, they know the daily workflows. So in terms of integration, they know where this should best fit. And they also, if you enlist them in development, then they can be super users and persuade their peers to actually use the tool. So our successful implementations did involve end users, but they use their labor judiciously. So I tried to get like a happy clinician here associated with when you do use these 6 tactics, you get successful implementation, which again, as we know, is so difficult. Final word for real world. Great big data, great sparkling technologies. I love the bold promises, but actually this depends on decisions made day in, day out by the frontline users. So managers need to increase the value for people on the front lines if they want to make this a reality. Thank you.